All right, we'll go ahead and get started. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices, and I'm delighted to convene today's meeting to order. So today is Wednesday, June 22nd, and we will be having a two-day regular ACIP meeting today. And with that, I will turn it over to Dr. Melinda Wharton to start with announcements.
Thank you, Dr. Lee. Next slide, please. Good morning and welcome to the June 22nd and 23rd virtual ACIP meeting. Copies of the slides being presented at today's meeting are or will be available on the ACIP website soon. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex-officio members. A few notes on meeting logistics for those of you who are listening in on the Zoom line. Please keep your lines muted at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the raise hand function in Zoom to virtually raise your hand. During the discussion period, Dr. Lee will first take questions from voting ACIP members and then from our ex-officio members and liaison representatives. Please keep your video off until there's a vote, and then we'll ask our ACIP voting members to please turn on their video. Next slide, please. The ACIP, the Advisory Committee on Immunization Practices is at its heart a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we'll be holding two oral public comment periods. The first will occur today at approximately 3 p.m. Eastern Daylight Time. The second oral public comment period will occur tomorrow, June 23rd, at approximately 1:10 p.m. Eastern Daylight Time. To create a fairer and more efficient process for requesting to make an oral comment, we ask that people interested in making a comment submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0062. Information on the written public comment process, including information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP policies and procedures, members of the ACIP agree to forgo certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, ACIP has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide, please. We are currently soliciting applications and nominations for candidates to fill upcoming vacancies on the committee. Detailed instructions for submission of names for potential candidates to serve as ACIP members are now available on the ACIP website. The deadline for applications for ACIP membership has been extended to August 15th, 2022 for the 4-year term beginning July 2023. We will be filling 6 positions this time, including the consumer representative position. And with that, I will turn the meeting back over to Dr. Lee. Thank you.
Thank you, Dr. Wharton. And just to let folks know, I'm actually having to dial in by phone if my computer reboots. So I'm going to take a roll call. And apologies if I miss anybody. I'm going to do my best to try and track by phone. But and then Dr. Wharton, actually, if my computer does not reboot in time, when we get to the liaisons, I may ask for your help in taking roll call. Okay, so we'll get going. So right now, I will, as a reminder, I will ask the ACIP members to state their name, whether they have any conflicts of interest, their name, their affiliation and whether they have any conflicts of interest. So we're going to go ahead and start with Dr. Bell.
Good morning. I am Beth Bell, clinical professor, Department of Global Health, University of Washington, and I have no conflicts.
Thank you. Dr. Lair?
Hello, good morning. This is Dr. Jamie Lair. I am in private practice at Cuga Family Medicine in Essex, New York, and I have no conflicts of interest.
Thank you. Dr. Cotton?
Good morning, Camille Cotton. I'm the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Harvard Medical School. I have no conflicts of interest.
Thank you. Dr. Sineas?
Good morning. I am Sybil Sineas. I am an internist and pediatrician. I'm an associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Chen?
Good morning, everyone. Wilbur Chen, professor of medicine and an adult infectious disease physician. I wear the hat of director of the travel medicine practice here at our university and at the University of Maryland School of Medicine. I also am the section chief of the Adult Clinical Studies section at the Center for Vaccine Development and Global Health. I have no conflicts. Thank you.
Thank you, Dr. Chen. Dr. Daly?
Good morning. I'm Matt Daly. I'm a senior investigator at the Institute for Health Research, Kaiser Permanente, Colorado, and an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts of interest. Thanks.
Thank you. Dr. Paling?
Good morning. This is Kathy Paling. I am professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you. Dr. Talbot?
Good morning. I'm Kip Talbot. I'm an associate professor at Vanderbilt University Medical Center, where I work as an adult infectious disease physician, and I have no conflicts. Thanks.
Thank you. Ms. McNally?
Good morning. Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Alt?
Morning. My name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Medical Center in Kansas City, Kansas. I have a conflict of interest with the HPV discussion. I've acted as a consultant for a group known as Pathovax, who's trying to make an HPV vaccine.
Thank you. Ms. Bata?
Good morning. Lynn Bata. I'm a public health nurse at the Minnesota Department of Health, functioning as an immunization clinical consultant, and I have no conflicts of interest.
Thank you. Dr. Brooks?
Yes, good morning. Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation in South Los Angeles.
Thank you. Dr. Long?
And I have no conflicts.
Oh, thank you. Dr. Long?
Good morning. This is Sarah Long. I'm a professor of pediatrics and a pediatric infectious disease doctor at Drexel University College of Medicine, and I have no conflict of interest.
Thank you. Dr. Sanchez?
Morning. I'm Pablo Sanchez. I'm a professor of pediatrics at the Ohio State College of Medicine, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital in Columbus. I have no conflict. Thank you.
Thank you. And this is Grace Lee. I'm a professor of pediatrics at Stanford University School of Medicine, associate CMO for Stanford Children's Health, and I have no conflicts. I believe I got all 15 members. Did I miss anybody? Okay. Thank you. Thank you, everyone, for being here today, and especially after it's been such a short interval since our last meeting. Next, I'll move on to our Ex-Officio and Liaisons, and as a reminder, I'll announce the organization name, and then please indicate if you are present and your first and last name. We'll start with Center for Disease Control and Prevention.
Good morning, Sam Posner, Deputy Director, NCIRD.
Thank you. I believe our colleague from Center for Medicare and Medicaid Services might be joining slightly later. We'll move to Food and Drug Administration.
Hi, good morning. Doran Feng, present on behalf of the U.S. Food and Drug Administration Office of Vaccines.
Thank you, Dr. Fink. Health Resources and Services Administration.
Good morning. This is Mayor Rubin representing Division of Injury Compensation Programs, HRSA.
Thank you. Indian Health Service.
Good morning. This is Dr. Matthew Clark representing the Indian Health Service.
Thank you, Dr. Clark. National Institute of Health.
Good morning. John Michael from the National Institute of Allergy and Infectious Disease representing the NIH.
Thank you. And Office of Infectious Disease and HIV/AIDS Policy.
Well, good morning. This is David Kim with the National Vaccine Program in OIDP in the Office of the Assistant Secretary for Health.
Thank you. We'll move on to our liaison representatives. American Academy of Family Physicians.
Good morning, Pamela Rockwell, Professor of Family Medicine at the University of Michigan, representing the American Academy of Family Physicians.
Thank you. American Academy of Pediatrics.
Good morning, Bonnie Maldonado, Professor of Global Health and Infectious Diseases, and I'm Chair of the Committee on Infectious Diseases for the American Academy of Pediatrics.
Thank you. American Academy of Pediatrics Red Book.
David Kimberlin, University of Alabama at Birmingham, editor of the AAP Red Book.
Thank you. American Academy of Physician Assistants.
Hi, good morning. Marie-Michelle Léger, Director of Clinical Education, AAPA.
Thank you. American College Health Association. We'll move on to American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Dr. Linda Ecker at University of Washington, present.
Thank you. American College of Physicians.
Good morning, Jason Goldman, General Internal Medicine, Private Practice, Coral Springs, Florida, Affiliated Associate Professor, Florida Atlantic University. Pleasure to be here representing American College of Physicians.
Thank you. American Geriatric Society.
Ken Schmader, present for AGS.
Thank you. America's Health Insurance Plans. We'll move on to American Immunization Registry Association.
Good morning, Rebecca Coyle is representing ARA.
Morning. American Medical Association.
Sandra Freihofer, General Internist in Atlanta, Adjunct Associate Professor of Medicine at Emory University School of Medicine, representing the American Medical Association.
Thank you. American Nurses Association.
Holly Carpenter, Registered Nurse, American Nurses Association.
Thank you. American Osteopathic Association.
Good morning, Stan Grog, present.
Thank you. American Pharmacists Association.
Good morning. This is Michael Hogue, Dean and Professor of the Loma Linda University School of Pharmacy and Professor of Preventive Medicine at the Loma Linda University School of Medicine, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
This is Susan Lett, Massachusetts Department of Public Health, representing AIM today. Thank you.
Thank you, Dr. Lett. Association for Prevention, Teaching, and Research.
Good morning. This is Christy Mulling-Jessel, Assistant Professor of the Department of Family Medicine, University of Pittsburgh, representing the APPR.
Thank you. Association of State and Territorial Health Officials.
Good morning, Dr. Lee. This is Nirav Shah, Director of the State of Maine CDC and the President of ASTO. Thank you.
Good morning. Biotechnology Innovation Organization.
Good morning, Dr. Lee. Phyllis Arthur, representing BIO.
Good morning. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Thank you. Canadian National Advisory Committee on Immunization.
Matthew Tunis here for NACI. Thank you.
Thank you. Infectious Diseases Society of America.
Good morning, Jim McCauley, Internal Medicine Pediatric Infectious Disease Physician, representing IDSA.
Thank you. International Society for Travel Medicine.
Good morning, Elizabeth Barnett, representing ISTM.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACO.
Thank you. National Association of Pediatric Nurse Practitioners.
Morning, Patsy Stinchfield, representing NAPNAP.
Morning. National Foundation for Infectious Diseases.
Good morning. This is Dr. Bill Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt and the Medical Director of the NFID. Present.
Thank you. National Medical Association.
Good morning. This is Dr. Pat Whitley-Williams,
Professor of Pediatrics and Chief of Pediatric Infectious Disease at Rutgers, RWJ Medical School. Good morning.
Thank you. Good morning. Pediatric Infectious Diseases Society.
Good morning. Sean O'Leary, representing PIDS.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman, representing SAM.
Thank you. And Society for Healthcare Epidemiology of America.
Good morning. Marcy Drees, Chief Infection Prevention Officer at Christiana Care, representing SHAE.
Thank you. And I'll go back and ask if any of our ex-officio or liaison representatives who are not yet able to speak are on and would like to announce themselves. Okay, I don't see any hands raised. So with that, I believe we do not have any opening remarks today, so we will move on to the first session of the day. And this morning, we'll start out with influenza vaccines with Dr. Kip Talbot as chair of the Influenza Vaccine Working Group. Dr. Talbot, the floor is yours.
Thank you. I'm so excited to talk about something besides COVID. All right, so we're going to talk about influenza. Next slide, please. So these are the influenza work group members, including ACIP members, ex-officio members, and liaison representatives and consultants. And they have put in a lot of hard work recently to discuss adults over 65 years of age. And so we're really excited to show you all of those results. Next slide. So recent work group discussions have included elements of the evidence to recommendations framework for influenza vaccination of persons aged greater than or equal to 65 years of age. And they have worked on the development of proposed recommendations for 2022 to 2023. Next slide. So today's session will include the following: preliminary estimates of 2021-2022 seasonal influenza vaccine effectiveness against medically attended influenza, and this will be presented by Jesse Chung. There'll be evidence to recommendations framework for influenza vaccination of persons aged greater than or equal to 65 years of age by Dr. Grosskopf, and there'll be summary and proposed recommendations by Dr. Grosskopf. Next slide. I'll hand it over. Thank you.
Thank you.
Hi, this is Jessie Chung. Can you hear me?
We can. Thank you, Dr. Chung.
Great. Thank you, everyone, and good morning. Next slide, please. All right, as a reminder, these are the four components of the 2021-22 U.S. influenza vaccines, which contain one H1N1, one H3N2, one B Victoria, and one B Yamagata virus. And as a reminder, the H3N2 came from a genetic clade 3C2A1B, subclade 2A1. Next slide, please. The results I'm sharing today come from the U.S. Flu VE network, which is made up of 7 research sites shown here that conduct active enrollment of patients seeking outpatient medical care for an acute respiratory illness that included cough and/or fever. Next slide, please. We restricted our analysis to patients eligible for influenza vaccine who sought care within 7 days of illness onset and were enrolled between October 2021 and April 2022. We used a test-negative case-controlled study design comparing vaccination odds among persons testing positive and negative for flu. We excluded persons who tested positive for SARS-CoV-2. Vaccination status was defined as receipt of 1 or more doses of influenza vaccine with data sources that included electronic medical records, immunization information systems, as well as self-report. VE was calculated from logistic regression models adjusted for study site, age, self-rated general health status, race and ethnicity, and month of illness onset. Next slide, please. The Flu VE network enrolled over 6,000 persons in this time frame, including 7% who tested positive for influenza and 30% who tested positive for SARS-CoV-2. There were 15 flu SARS-CoV-2 co-infections detected. Among the influenza positives, as shown in the pie chart below, 94% were H3N2 viruses. All of the genetically characterized viruses belong to clade 3C2A1B, subclade 2A2, and no influenza B viruses were detected among participants. Next slide, please. This figure shows the distribution of influenza positive cases in gold over time compared to SARS-CoV-2 positives in blue and flu SARS-CoV-2 negatives in gray. The line depicts the percent of specimens that tested positive for influenza. Next slide, please. This slide shows the preliminary vaccine effectiveness against any influenza A and H3N2 among all study participants aged 6 months and older. Overall VE against influenza A viruses was 34%, with a statistically significant 95% confidence interval that ranged from 19 to 46. VE against influenza H3N2 was 35% overall, with a 95% confidence interval that ranged from 19 to 47%. Next slide, please. When broken down into 3 age groups, VE against H3N2 was highest in the pediatric age group, including persons aged 6 months to 17 years, for whom VE was 44% and statistically significant. VE among adults aged 18 to 49 years was 27%, with a 95% confidence interval from -3 to 48%. We were unable to calculate an adjusted vaccine effectiveness estimate for adults aged 50 and older due to the limited number of cases enrolled. And you can see we only enrolled 67 H3N2 cases in this age group. Next slide, please. To summarize, the preliminary findings for the 2021-22 U.S. season indicate that vaccination reduced ARI due to H3N2 by 35%. Almost all viruses sequenced nationally belong to clade 3C2A1B, subclade 2A2. We observed very low influenza prevalence among all our enrollees this season. And finally, the 2022-23 Northern Hemisphere influenza vaccines will include an updated reference virus for H3N2 to clade 3C2A1B, subclade 2A2. And they'll also include an updated B Victoria component. Thank you to all the collaborators identified in the next few slides, and this will conclude my presentation. Thank you.
Thank you. If it's okay with you, we'd like to open the presentation for questions. And I see Dr. Paling has raised her hand.
Good morning. Thank you, Dr. Jong, for a great presentation and sharing the recent. Would you remind us of the percent that were both flu positive and COVID positive? And did you observe any differences between those that had just flu versus those that were co-infected? Thank you.
Thanks, Dr. Paling. I first want to clarify, I'm not a doctor. I have my master's in public health and epidemiology. But to answer your question, we only identified 15 total co-infections. So the percent is very, very small. And we did not really do any comparisons because there were so few co-infections.
Are there any additional questions? Any questions from our liaison members? Okay, well, why don't we go ahead to Dr. Lisa Groskopf to discuss influenza vaccination of older adults. And Dr. Groskopf, if you wanted to discuss that and then move into your summary, feel free, or we can pause and take questions in between.
Yes, whatever works best at the end of this presentation would be fine. So good morning and thanks very much. In this presentation, this first one, we're going to summarize the evidence to recommendations framework discussion by the work group for the review of influenza vaccines for persons aged 65 years and older. Next slide, please. We'll first briefly review the background for this assessment, followed by a summary of the evidence to recommendations framework, and we'll end with the work group conclusion and proposed recommendation. Next slide. First, a review of the background. Persons aged 65 years and older are at increased risk of severe illness, hospitalization, and death due to influenza relative to younger age groups. This age group has been a target population for annual influenza vaccination since the early 1960s. However, influenza vaccines are often less effective for people in this age group compared with younger populations. The table in the inset is a summary of annual estimates of U.S. influenza vaccine effectiveness from the CDC U.S. Flu VE network for the 2011-12 through 2019-20 seasons. Estimated vaccine effectiveness for all viruses and all vaccine types for those 65 and older is shown in the rightmost column and is compared with estimates for all ages combined and, again, all vaccines in the middle column. VE was substantially lower for those 65 and older than for all ages as a group for 4 out of the 9 seasons shown. Next slide. All of the influenza vaccines currently approved and available in the United States, with the single exception of the live attenuated influenza vaccine, are approved for ages 65 and older. These include 5 standard dose unadjuvanted influenza vaccines, collectively referred to as SDIIVs or standard vaccines in this talk, 1 high-dose inactivated influenza vaccine or HDIIV, 1 adjuvanted inactivated influenza vaccine or AIIV, and 1 recombinant influenza vaccine or RIV. ACIP has previously expressed no preferential recommendation for any specific influenza vaccine or vaccines for this age group. Next slide. 3 influenza vaccines were of specific interest for this review. The high-dose inactivated influenza vaccine, currently available as Fluzone High-Dose Quadrivalent, or HDIIV4, was approved as a trivalent in 2009 for ages 65 and older. It contains 4 times the hemagglutinin, or HA, dose per virus compared with SDIIVs. Initial approval was under the accelerated pathway based upon superior immunogenicity to SDIIV3. Subsequent approval under the traditional pathway occurred in 2014 following demonstration of superior efficacy to standard dose SDIIV3 in a 2-season randomized trial among 32,000 participants aged greater than or equal to 65 years. HDIIV4, the currently available quadrivalent formulation, was approved in 2019 on the basis of non-inferior immunogenicity to HDIIV3 and replaced HDIIV3 for the 2020-21 season. Next slide. The adjuvanted influenza vaccine, also an inactivated vaccine, currently available as Fluad Quadrivalent or AIIV4, was approved in the U.S. as a trivalent, AIIV3, in 2016 for ages 65 and older, but had previously been in use in Europe for many years, as early as 1997. It contains the adjuvant MF59. It was approved under the accelerated pathway based upon non-inferior immunogenicity to unadjuvanted SDIIV3. In a post-marketing efficacy study, the quadrivalent AIIV4 was compared with Tdap in a 2-season randomized trial among 6,700 persons aged 65 and older. The primary efficacy endpoint for this study, which was prevention of PCR-confirmed protocol-defined influenza-like illness, or ILI, due to any influenza, was not met. It was noted that 88% of the antigenically characterized viruses from cases in the active arm were antigenically mismatched. Efficacy was noted against PCR-confirmed CDC and WHO-defined ILI due to any virus. AIIV4 is approved under the accelerated pathway and replaced AAIV3 for the 2021-22 season. Next slide. The last vaccine, Block Quadrivalent, is a little different from the previous 2 in that it was not initially approved in the U.S. for 65 and older. Block Quadrivalent was initially approved as a trivalent Block, RIV3, in 2013 for ages 18 through 49 years. This vaccine has 3 times the HA dose per virus compared with SDIIVs. It's a recombinant HA. It has no viruses or eggs used in production. It was initially approved under the traditional pathway based upon efficacy demonstrated in a randomized placebo-controlled study among persons aged 18 through 49 years. Subsequently, it was approved for 50 years and older in 2014 under the accelerated pathway on the basis of immunogenicity studies among persons in this age group. RIV4, the quadrivalent formulation, which is currently available, demonstrated efficacy relative to SDIV4 in a single-season randomized study conducted among about 8,600 persons aged 50 and older. RIV3 and RIV4 gained traditional approval for ages 50 and older in 2017, and RIV4 replaced RIV3 for the 2018-19 season. So just as a note to recap on these three vaccines, all of them are currently available, as are the rest of the influenza vaccines that are available as quadrivalent formulations. We no longer, as of this season, have trivalents. Next slide. The grade summary for this review was presented in February 2022. The question of focus was, do the relative benefits and harms of HD-AIV, AIIV, and RIIV, as compared with one another and with other influenza vaccines, favor the use of any one or more of these vaccines over other age-appropriate influenza vaccines for persons 65 and older? Inherent in this question were 6 relevant comparisons, which are laid out here. Just to review, they are HD-IIV versus SD-IIV, AIIV versus SD-IIV, and RIV versus SD-IIV. And then in addition, 3 more where the different vaccines of interest are compared with one another: HD-IIV versus AIIV, HD-IIV versus RIV, and AIIV versus RIV. One thing to note on the slides going forward: the term higher dose and adjuvanted influenza vaccines replaces the collective term previously used in these discussions to define collectively high-dose adjuvant and recombinant vaccines. Previously, we used the term enhanced influenza vaccines. The reason for this change is that while there is precedence for the use of the term enhanced influenza vaccines in the literature, it does not have a strict definition and might lead to confusion as to what counts as such a vaccine, particularly as new vaccines emerge going forward. Next slide. The Picot for this question was as follows. The population of interest was adults aged 65 years and older. Interventions included the higher dose, adjuvanted or recombinant influenza vaccines, so collectively higher dose or adjuvanted vaccines, in trivalent or quadrivalent formulations. Comparators included standard dose unadjuvanted influenza vaccines, as well as the higher dose and adjuvanted influenza vaccines, which you can see show up in both the intervention and the comparator box because they could be compared with one another. Critical outcomes of interest included for benefits influenza illness, influenza-associated outpatient emergency department visits, influenza-associated hospitalizations, and influenza-associated deaths, all due to any viral type or subtype and defined by lab confirmation, diagnostic codes, or clinical definitions. Critical safety outcomes included any solicited systemic adverse event grade 3 or higher, and Guillain-Barré syndrome. Lastly, important outcomes included any solicited injection site adverse event grade 3 or higher, and any serious adverse event or SAE. Next slide. With that background, we'll summarize the workgroup discussion and considerations of the ETR domain by domain, starting with the first domain, public health importance. Next slide. In discussing the significance of influenza among persons 65 and older, the workgroup reviewed influenza hospitalization and surveillance data, as well as this analysis by Rolfes et al., which estimated the burden of influenza in the U.S. by age group for the 2010-11 through 2015-16 season, using data from routine influenza surveillance, outbreak investigations, and survey data describing proportions of persons seeking health care. The highest burden of influenza hospitalizations and deaths was among those 65 and older, with estimated ranges of 87,000 to 521,000 hospitalizations, 3,000 to 17,000 excess pneumonia and influenza deaths, and 9,000 to 43,000 excess respiratory and circulatory deaths over the 6 years studied. Next slide. The workgroup was unanimous in the view that influenza among older adults is a problem of public health importance. All responses to this question were yes. Next slide. The next domain is benefits and harms. The systematic review and grade were previously summarized in some detail in previous meetings, most recently the grade at the February 2022 meeting. For this discussion, we're going to focus primarily on the critical outcomes selected by the work group. Those are, again, for benefits, prevention of influenza illness, influenza-associated outpatient and emergency department visits, influenza-associated hospitalizations, and influenza-associated deaths. For harms, the critical outcomes were any solicited systemic adverse event grade 3 or higher, and Guillain-Barré syndrome. Next slide. We have several tables, and we're going to start first with a brief discussion of the comparisons of the higher dose and adjuvanted influenza vaccines with one another, first with regard to benefits. So this table summarizes all three of the comparisons of the vaccines of interest against one another. There are subheaders in the table for high dose versus adjuvanted, high dose versus recombinant, and adjuvanted versus recombinant, just for orientation. So among all of these three comparisons on the slide, there was only one randomized study which was relevant for all three comparisons. This was a very small study which included, again, all three vaccines, had approximately 30 participants per group, and it was primarily an immunogenicity study. It was not powered to examine efficacy, but it reported influenza PCR positive ILI as an exploratory outcome. Given the size and power of the study, there were no significant differences observed for any of these outcomes. In each comparison, this is very low certainty evidence, downgraded for risk of bias as was an open label study, as well as for imprecision. There were no other randomized studies for any of these three comparisons and no other studies using laboratory confirmed influenza outcomes. The remainder of the studies retrieved for these comparisons were retrospective cohort studies, including diagnostic code-defined outcomes. Since the last presentation, following some additional discussion, the certainty results containing these data have been downgraded an additional step for risk of bias due to concerns over potential for residual confounding. So some of those certainty levels will be lower than what was seen in February. For the high dose versus adjuvanted comparisons, neither vaccine was effective in was favored in retrospective cohort studies for the outcomes of influenza-associated outpatient and ER visits or influenza-associated hospitalizations with very low certainty. Downgrading for this was for the outpatient studies, for risk of bias and for inconsistency because two studies were performed during the same season that had substantially different estimates, and for the hospitalization outcome for risk of bias and imprecision. For the high dose versus adjuvanted comparison, that summarizes the retrospective cohort data. In the case of the estimates for high dose versus recombinant and adjuvanted versus recombinant, which are the latter two outcomes on the slide, there was evidence of benefit for the recombinant vaccine for prevention of influenza-associated hospitalizations, again, both favoring recombinant with low certainty. These results, however, came from only one study performed over one influenza season. Next slide. Considering together the results among studies affording direct comparisons of benefit outcomes among the higher dose and adjuvanted vaccines, it was felt that the evidence is insufficient currently to inform a decision for any one over the others. In the interest of time, we have not resummarized the safety results which were presented in February. However, it was also reassuring that among studies providing safety data for these comparisons, which included one RCT comparing high-dose versus adjuvanted vaccine for safety outcomes, there were no results favoring any vaccine. Overall certainty for these outcomes was low, primarily due to imprecision stemming from low event counts and often small sample sizes. Next slide. The work group then discussed comparisons of each of the higher dose or adjuvanted vaccines with standard dose unadjuvanted vaccines. This slide and the two that follow each focus on a single vaccine comparison. This one is for high dose versus standard dose. For high dose versus standard dose for influenza illness, we have a large 2-season randomized trial which noted a relative risk of 0.76, translating into a relative vaccine efficacy of about 24%, favoring high dose compared with standard dose. This was high certainty evidence. For flu-associated outpatient and ER visits, there was evidence favoring high dose with a relative risk of 0.7 from a retrospective cohort study covering 4 seasons with low certainty, downgraded for risk of bias. For hospitalizations, there was evidence of relative effectiveness favoring high dose with a relative risk of 0.79 from a cluster randomized trial conducted within a network of 823 nursing homes during a single season. This was judged to be moderate quality evidence. Though it is a cluster randomized trial, it was reassuring that the risk estimate and by extension the relative VE was similar to that obtained in the large randomized efficacy trial at the top of the slide. There was also evidence from observational studies favoring high dose over standard dose for influenza-associated deaths with an effect estimate of 0.67, which was low certainty evidence. Next slide. So this next slide moves on to comparisons of adjuvanted versus standard dose, and we're still talking about benefits outcomes, so efficacy and effectiveness. For the adjuvanted vaccines versus standard vaccine, there was no RCT using lab-confirmed influenza outcomes that was retrieved. One RCT, primarily a safety study, examined occurrence of influenza identified strictly by a symptomatic definition and saw no difference. There were several studies that spoke to the outcome of influenza-associated outpatient visits, but evidence here was variable. 2 retrospective cohort studies were identified that examined code-defined outcomes during the same season. No effect was seen in the pooled estimate, and this evidence had to be downgraded for risk of bias as well as inconsistency because the 2 estimates from the same season had substantially different results. There were 2 smaller observational studies which combined favored AIIV with a risk estimate of 0.64. For hospitalizations, there was evidence favoring AIIV with an RR of 0.79 and moderate certainty from a cluster randomized trial using diagnostic code-defined pneumonia and influenza outcomes. This trial was of similar design and was conducted in a similar nursing home network to the cluster randomized trial described in the previous slide for the high-dose vaccine. There was also evidence favoring AAIV from 3 retrospective cohort studies, again using code-defined hospitalizations, and from 2 smaller observational studies. These latter 2 estimates for hospitalizations were low certainty evidence. Next slide. So this is our third slide for comparisons of our vaccines of interest versus standard dose vaccines, and this one is for recombinant versus standard dose. For this comparison and for recombinant vaccine data in general, we have fewer studies. For influenza illness, there were 2 RCTs, a smaller one dating from about 2010, comparing RIV3 with SDIIV3, and a more recent larger trial comparing RIV4 and SDIIV4. This was high certainty evidence, but the risk estimate was equivocal. Of note, for the more recent larger study, which drives most of the results in the meta-analysis for this particular comparison, the total study population was 50 years and older. For the study population as a whole, there was reduction in PCR-confirmed influenza with IRIV4 compared with SDIIV4 with a relative risk of about 0.7. PCR-confirmed influenza was the primary outcome defined by the study. However, no reduction in risk was seen for persons aged 65 years and older in a sub-analysis. The work group, however, felt that this work was nonetheless important because of the reduction seen for ages 50 and older, and the fact that reduction in risk for some other outcomes, including notably culture-confirmed influenza, was seen in the subset of those 65 and older. There was also evidence of benefit against hospitalization from a large retrospective cohort study among Medicare beneficiaries, again using diagnostic code-defined outcomes, which yielded a risk estimate of 0.83 favoring recombinant vaccine and was judged low certainty evidence. Next slide. This slide summarizes harms outcomes for the comparisons that we just went over in the last 3 slides of each vaccine of interest versus standard dose unadjuvanted vaccine. In each case, neither vaccine was favored for any of the 2 critical safety outcomes across any of the 3 comparisons. Overall quality of these estimates was low to very low. This was primarily, generally, due to small event counts and often small sample sizes in these studies, as well as the relative rarity of Guillain-Barré syndrome. Next slide. Discussion points in the work group are summarized as follows for the findings we just reviewed. It was recognized that among the 3 higher dose and adjuvanted vaccines, the most data are available to support high dose, which had some evidence favoring its benefits for all 4 of the selected critical efficacy and effectiveness outcomes. This includes, notably, the very large 2-season randomized trial, which noted a relative VE of 24% for high dose versus standard dose vaccine. However, considering data for the various outcomes across the vaccine comparisons, it was also noted that the most data were available across the board for hospitalizations. While all of the efficacy outcomes were regarded as critical, hospitalizations of particular interest for being a relatively common and also severe outcome for this age group. For this outcome, there is evidence supporting each of the 3 higher dose or adjuvanted influenza vaccines over standard dose vaccines. These estimates were considered moderate certainty for high dose and for adjuvanted. In each case, this was driven by findings from large cluster randomized trials. Evidence was just as low certainty for hospitalization outcomes for the recombinant vaccine. Next slide. Overall, in the discussions of these factors and looking over these findings, it was also noted that relative VE varies from season to season, that the benefits of one vaccine compared with one another are not necessarily static, and we might not see relative benefit for any given vaccine combination, one vaccine over another being better in every season. In some seasons for multi-season studies, no benefit was seen for the higher dose or adjuvanted vaccine over standard. And finally, it seems that what performs better in one season might not in another. Next slide. Oh, sorry, keep on the same slide, apologies. With regard to safety, discussion among the work group was summarized as follows. There were really no concerns identified from the findings for the critical safety outcomes from the review. However, there was discussion concerning the overall level of certainty for these outcomes, which was overall low to very low, depending on the comparison and the outcome. The work group was concerned that it's important to emphasize that this is due to a low level of certainty in the evidence, largely due to imprecision of the effect estimates, not uncommon with safety studies, generally due to small event counts and often for some studies, small sample sizes. They felt strongly that it should be emphasized that this is not to be interpreted as a safety concern. Next slide. For the framework questions concerning benefits and harms, for benefits, overall level of certainty was low for each vaccine comparison. For harms, overall certainty was low for high dose and standard dose. For high dose versus standard dose and adjuvanted versus standard dose, and very low for recombinant versus standard dose. Next slide. For the question of how substantial are the desired anticipated effects, approximately half the work group indicated that they are moderate, but a substantial minority also selected varies, acknowledging the variability of influenza VE from season to season. Next slide. With regard to the substantiality of the undesired anticipated effects, the majority work group opinion was that these are minimal. Next slide. Considering all of these findings and factors, the majority work group sentiment was that the balance of benefits and harms favors the intervention. Next slide. So moving on to our next domain, which is values. We found no published evidence reflecting values of U.S. seniors concerning higher dose and adjuvanted vaccines specifically, or the relative importance of the selective outcomes. However, one aspect that might speak a little bit to values, which we're going to discuss later in a bit more detail, there are recent analyses of CMS data for Medicare beneficiaries, which suggests that the majority of community-dwelling Medicare beneficiaries aged 65 and older have already received one of these 3 vaccines in recent seasons. This suggests possibly that some seek out these vaccines specifically. However, it was also raised that provider choices and recommendations that are made to people getting vaccines are also important in determining what vaccines are received. Next slide. The expressions of the work group regarding the questions for this domain reflect some degree of uncertainty. The majority indicate that they thought that the target population probably feels that the desirable effects of the new recommendation are large relative to the undesirable effects. Also, there was probably not important uncertainty or variability in how people value the main outcomes evaluated. Next slide, sorry. And one more slide. Next domain is acceptability. No literature was found reflecting the acceptability of our vaccines of interest among U.S. seniors. A number of studies and papers were found that reflected questions such as willingness to pay for specific vaccines over others, for example, but most of these were not U.S. papers and don't reflect U.S. payment for influenza vaccines or the U.S. population. However, it was felt that some indirect evidence of the acceptability of high-dose adjuvanted and recombinant influenza vaccines among persons 65 and older can be seen in recent analyses of vaccine effectiveness among Medicare beneficiaries, which suggests that most 65 and older have already received a high-dose or higher dose or an adjuvanted vaccine in recent seasons. These analyses were studies of vaccine effectiveness against hospitalizations and other outcomes, and there's some of the papers that we have retrieved in our review of literature, so some of them are reflected, actually all of them reflected are in the tables that you saw earlier. There were some exclusions in the study population. For example, one of the more significant ones is that persons residing in nursing homes at the time of vaccine administration were excluded. And then again, also, not all vaccinations are recorded in the Medicare database, so we can't say that the study populations for these papers include the entire universe of Medicare beneficiaries. The analytic data sets contain 12 to 13 million people each season. The proportion of those who received high-dose, adjuvanted, or recombinant vaccine each season is summarized in the table. For each season, the majority of individuals in this data set had received one of these three vaccines, with approximately 81% having received one in the 2019-20 data. While this is not direct evidence of acceptability to all key stakeholders, the current degree of uptake suggests at least some current level of acceptability to vaccine providers and to recipients. Next slide. For the question of whether the intervention is acceptable to key stakeholders, the majority work group response was yes. Next slide. Now the domain of resource use. There are multiple published economic evaluations of high-dose and adjuvanted vaccines compared with standard vaccines. Given the possibility of a recommendation for more than one of these vaccines over SDIIVs, an economic analysis was conducted. Next slide. For this section, we'll present an analysis by Dr. Feng of the CDC Immunization Services Division. We are extremely grateful to Dr. Zhu and also Dr. Andrew Leidner and their ISD colleagues for this work and for the slides that follow. Next slide. The objective of this work was to conduct a cost-effectiveness analysis of use of higher dose and adjuvanted influenza vaccines, that is again, high dose, recombinant, and adjuvanted, for adults aged 65 and older in the US compared with standard dose unadjuvanted influenza vaccines from the societal perspective. Next slide. The assumptions for the base case were drawn from the averages of 2017-18 through 2019-20 influenza season disease burden, vaccination coverage, and vaccine effectiveness. The basis for the selection of these three seasons is that they are some of the few seasons in which we have relative estimates for all relevant vaccine comparisons that are available within the context of the same study. These estimates actually come from the Azuriad et al. Studies that were summarized on an earlier slide. The estimates that were used by Zurieta et al. Estimated relative vaccine effectiveness of these various vaccine comparisons against pneumonia and influenza diagnostic-coded hospital encounters, that is, inpatient stays and emergency department visits combined. Those are the particular estimates from these papers that were used for these assumptions. Using the base case assumptions, the incremental cost-effectiveness ratios in dollars per quality were $52,000 for high dose versus standard dose, $60,100 for adjuvanted versus standard dose, and were cost-saving for recombinant versus standard dose. Average cost-effectiveness ratios were $6,600 for high dose versus no vaccine, $7,600 for adjuvanted versus no vaccine, and were cost-saving for both the recombinant versus no vaccine and standard dose versus no vaccine. This slide presents the estimated numbers of health outcomes for each vaccine type under the base case set of assumptions. The total number of health outcomes are in the black text, while the red text reflects the difference between the high dose, adjuvanted, and recombinant vaccines and the standard dose vaccine. Each vaccine, HDIIV, AIIV, and RIV, was estimated to result in fewer illnesses, hospitalizations, and deaths. Looking across the three vaccines, approximately 2,000 additional deaths would be prevented with enhanced flu vaccines. This assumes current use of higher dose and adjuvanted vaccines of 80% in the population age 65 and older. It was further estimated that an additional approximately 400 deaths might be prevented if 100% of these vaccinated adults received instead one of the higher dose or adjuvanted vaccines. Next slide. To get an idea of the potential impact of different scenarios of relative VE and influenza burden on the incremental cost-effectiveness ratios, the 2017-18, 2018-19, and 2019-20 estimates for VE were applied to the disease burden data from 10 consecutive influenza seasons from 2010-11 through 2019-20. The chart here, just for orientation, has three clusters of 3 columns each, one using the 2017-18 relative VE estimates, the middle cluster, the 2018-19 VE estimates, and the left cluster, the 2019-20 VE estimates. Within each cluster is a column for each comparison of interest: high dose versus standard dose, adjuvanted versus standard dose, and recombinant versus standard dose by season. You can see that the variability in the CE ratio by there's variability in the CE ratio by VE, vaccine comparison, and season, with some scenarios being cost saving. Next slide. To summarize these results from the previous slide in a more visual format, a cost effectiveness curve was constructed. On the y-axis is the percentage of scenarios from the previous slide that fell below a given cost-effectiveness value that is represented on the x-axis. So we can see that 20% of the scenarios were cost-saving, 50% cost less than $43 per quality gained, and 95% cost less than $195,000 per quality gained. Next slide. In summary, incremental CE ratios for higher dose and adjuvanted vaccines versus standard vaccines vary considerably based upon underlying VE and influenza season severity. In modeling the various assumptions, 20% of the scenarios were cost-saving, and 95% of scenarios were under $195,000 per quality. Next slide. Oh. This analysis has some limitations. One is that the modeling work indicates, again, substantial uncertainty in estimates of value due to multiple product comparisons, as well as the inherent variability of influenza burden and VE from season to season. Also, as noted earlier, the VE assumptions here were derived from estimates obtained in a retrospective cohort study of vaccine for the prevention of influenza-associated hospital encounters. These estimates are not from randomized trials, in part because randomized trials are too few in number to be able to find sufficient assumptions for this model. Also because it is difficult to find estimates for all of the relevant outcomes during the same influenza season. It should also be noted that VE might differ for different outcomes, even for the same vaccine comparison within the same season. That is to say, VE for hospitalization or hospital encounters and ER visits will not necessarily be the same as VE for clinical illness or other outcomes. Next slide. Before moving on, we have much gratitude for all of our colleagues who contributed to this work, and in particular for Dr. Zhu for designing and performing this analysis. We're very grateful. Next slide. On the question of whether the intervention is a reasonable and efficient allocation of resources, it was acknowledged that given the variabilities associated with influenza burden and vaccine effectiveness, cost effectiveness of higher dose or adjuvanted vaccines will vary from season to season. However, overall, the work group felt that a recommendation to use higher dose and adjuvanted influenza vaccines over standard dose vaccine would be a reasonable and efficient allocation of resources. A minority voiced that it would probably be a reasonable and efficient allocation of resources, and a smaller minority indicated that this would vary. Next slide. The next domain is equity. Racial and ethnic disparities in overall influenza vaccine coverage and in rates of severe influenza illness have been documented in several studies. Mahmoud et al. Examined receipt of high-dose vaccine versus all other seasonal influenza vaccines combined as a group among Medicare beneficiaries aged 65 and older during the 2015-16 influenza season. In addition to disparities in receipt of any seasonal influenza vaccine, a finding that has borne out in many other papers, the authors noted disparities in the use of high-dose vaccine compared with standard dose vaccine by race and ethnicity. Compared with white recipients, those of Black or Asian race and of Hispanic ethnicity were less likely to receive the higher dose vaccine. The results are summarized in the table, where in the center column you can see the adjusted odds for receipt of high dose versus standard dose by race and ethnicity. And for each category, Black and Asian race and Hispanic ethnicity, the odds of receiving high dose were significantly lower than for white recipients. Next slide. In discussing the potential impact of a new recommendation on equity, it was recognized that impact depends upon underlying causes of the differences in receipt of these vaccines. Potential factors include, but are not limited to, cost, differences in practice settings, and differences in linkage to care. It was also noted that the Mahmoud study occurred during the 2015-16 season. At this time, AIIV had not yet been introduced in the US, and RIV was relatively new to the market, so there were somewhat fewer options for this age group. Nonetheless, given what is known about persisting disparities in influenza vaccination coverage in the population as a whole, inequities in this age group remain a concern. While it's not possible to know whether a recommendation for higher dose or adjuvanted vaccines would positively impact equity, the sense was that there is not a basis to predict negative impact. Next slide. On the question of equity, what would be the impact on health equity? The majority of the work group expressed the view that a new recommendation would probably increase equity. A smaller proportion expressed that the intervention would increase equity or that it would probably have no impact. None indicated that equity would be reduced or probably reduced. Next slide. So our last domain is feasibility. In the workgroup discussion, a point that was thought to speak to the issue of feasibility was again the observation discussed earlier in relation to acceptability, that published analyses of CMS data suggest that most community-dwelling, non-nursing home resident Medicare beneficiaries aged 65 and older have already received a higher dose or adjuvanted influenza vaccine during recent seasons. While there were differences in the proportions that received high dose versus adjuvanted versus recombinant relative to one another, and there was some shifting in those proportions over the 3 seasons that we examined, these vaccines already appear to be in established use in this population. From a reimbursement perspective, CMS already reimburses for all influenza vaccines that are approved for this age group. There are some differences in the reimbursement rates. HD-IIV, RIV, and AIIV are reimbursed at a higher rate than SD-IIVs. As of 2021-22, $65 to $67 per dose for the higher dose and adjuvanted vaccines versus $20 to $28 for single dose presentations of the SD-IIVs. There's a bit more spread in the figure for the standard dose vaccines, mainly because the reimbursement for Flucelvax Quadrivalent, the cell-based vaccine, is somewhat higher than the remaining vaccines, which are egg-based. Higher dose and adjuvanted influenza vaccines are also similar in administration and storage to other intramuscular influenza vaccines. Next slide. Overall, the work group felt that an intervention recommending higher dose or adjuvanted influenza vaccines would be feasible to implement. Next slide. Finally, a summary on the work group's conclusion. So in considering again all of the ETR domains and with the intervention being higher dose or adjuvanted vaccines over SD-IIVs for persons age 65 and older, the breakdown for the domains was as follows. Influenza among older adults, it was agreed, is a problem of public health importance. Substantiality of desirable and anticipated effects of an intervention was felt to be moderate on average but variable. Substantiality of the undesirable anticipated effects was felt to be minimal. Balance of the desirable and undesirable effects was felt to favor the intervention. Overall certainty of the evidence for the higher dose and adjuvanted vaccines versus the standard vaccines was low for the critical efficacy and effective outcomes. The breakdown for the critical safety outcomes was low for high dose and adjuvanted and very low for recombinant. But again, the low to very low assignments of certainty were primarily due to low precision of estimates gathered from studies that often had small event counts and small sample sizes. The work group reinforced that overall these vaccines have been demonstrated to be safe. While there were few specific data to discuss relevant to values, the work group felt that the target population probably feels that the desirable effects outweigh the undesirable effects, and that there's probably no important uncertainty or variability in how people value the main outcomes. The intervention was felt to be likely to be acceptable to key stakeholders and a reasonable and efficient use of resources. With regard to equity, most felt that the intervention would probably increase equity. None responded that it would decrease equity. And finally, the intervention was felt to be feasible to implement. Next slide. In considering the elements of the ETR previously discussed with regard to overall balance of consequences inherent in a new recommendation, the majority of the work group felt that desirable consequences clearly outweigh undesirable consequences in most settings. A somewhat lesser proportion responded that they thought that desirable consequences probably outweigh undesirable consequences in most settings. None of the other options were selected. Next slide. On the question of whether there is sufficient evidence to move forward with a recommendation, the majority of the work group responded yes. Next slide. The work group discussed several potential recommendations. The first was to make no change in the recommendation. That is to say, that any age-appropriate influenza vaccine is recommended for persons age 65 and older. The second, that high-dose vaccine is recommended when available, and that if not, any age-appropriate vaccine can be used. The third, that high-dose vaccine is recommended when available. If not, then either adjuvanted or recombinant if available, and if none of these three is available, then any age-appropriate vaccine may be used. And finally, the fourth, that high-dose, adjuvanted, or recombinant are recommended when available. If none of these three vaccines is available, any age-appropriate vaccine may be used. The majority of the work group opted for this fourth option. Next slide. The next several slides go over some discussion points that emerged during discussion of the ETR, as well as during discussion of potential recommendation language that was just summarized. A number of points were raised by the work group in the discussion of these factors, some of which concerned the evidence base. It was acknowledged that randomized trials, ideally against lab-confirmed outcomes, are the most desirable evidence. However, such trials are few in number, are very resource-intensive to implement, and are therefore not easily executed over repeated seasons. Given the variability of influenza seasons and of vaccine effectiveness, it is difficult to assume that findings from a few seasons will generalize to all or most seasons. In this case, we have only 2 randomized efficacy trials comparing higher dose and adjuvanted vaccines versus standard dose vaccines with lab-confirmed outcomes. The 1-2 season trial for high dose versus standard dose, and the other for recombinant versus standard dose. These trials covered 2 and 1 seasons respectively. There was no comparable randomized trial comparing adjuvanted to standard dose. The trial mentioned at the start of this presentation of AIIV4 versus Tdap was not part of the grade analysis in this review because the primary focus was on studies providing estimates of relative VE of influenza vaccines compared with one another. As noted, this study did not demonstrate efficacy for its primary outcome. However, the majority of antigenically characterized viruses from the active arm of that study were due to antigenically drifted viruses. This demonstrates another difficulty with randomized trials of influenza vaccines. If the study is performed in what turns out to be a season of meaningful mismatch between vaccine and the predominant viruses in circulation, it might be difficult or impossible to draw conclusions either way about efficacy from the work of that season. An analogous, although more extreme example of this occurred with an earlier trial of high-dose vaccine versus standard-dose vaccine, which occurred during what would become the 2009 H1N1 pandemic. In this study, no cases occurred to viruses antigenically matched with vaccine viruses due to the widespread circulation of the novel pandemic virus, which essentially replaced the other viruses in circulation for that season. Next slide. While randomized trials are critical from a practical standpoint, decisions regarding potential preferential recommendations for influenza vaccines might need to draw from observational studies and not restrict to randomized controlled trials, while acknowledging the limitations of the observational studies in order to gain perspective on performance across seasons. It was acknowledged that the most data for the most outcomes are available to support the high-dose vaccine. However, it was also noted that while a single randomized trial of RIV4 versus IIV4 did not demonstrate benefit for the primary outcome for 65 and older, it did demonstrate benefit for some other outcomes in this age in our age subgroup of interest, and also for the population as a whole for 50 and older. It was also noted that there is evidence to support adjuvanted vaccine from a cluster randomized study and several observational studies. Another point was raised that a recommendation for a single vaccine over all others might lead to confusion if that vaccine does not demonstrate consistent benefit across future seasons. Conversely, it was felt that a recommendation for any of the 3 vaccines provides a balance of science and practicality given what we know about the variability of influenza seasons and vaccine effectiveness. Next slide. Finally, as noted earlier, there are fewer data comparing HEIIV, AIIV, and RIV with one another. Among the available studies, the most provide data for the high-dose vaccine versus adjuvanted vaccine comparison. In these 3 comparisons as a whole, the only relative benefit was seen for the recombinant vaccine versus adjuvanted vaccine and the recombinant vaccine versus high-dose vaccine. But these 2 outcomes were based on a single study from a single influenza season. Overall, current evidence was felt to be insufficient to recommend one vaccine over the others. However, it is also likely that we will have more comparative data to examine in the near term, possibly with the current quadrivalent formulations of the high dose and the adjuvanted vaccines, for which we did not have any data to use in this review. Next slide. Other points spoke to feasibility and acceptability issues. For example, that a recommendation for one of 3 vaccines when available provides flexibility for providers. For example, for those who care for adults across an age spectrum, stocking RIV might be more practical since it's approved for ages 18 and older and not only for 65 and older. Another point raised was that this approach minimizes some of the risk associated with a recommendation for one vaccine above all others. For example, if there are unexpected delays in vaccine availability or manufacturing problems. The work group subsequently discussed proposed language, which will be shown in the next presentation. Thank you very much. This ends this talk, and I would be happy to take any questions.
Thank you, Dr. Groskopf. This presentation is now open for questions. Dr. Palin.
All right, Dr. Groskopf, I want to say a very special thank you to you, your entire team, and the work group for presenting such clear information on enormous amounts of data. This is really important. And I very much liked the way the work group went through in the discussion of the considerations and agree with those. I was hoping that you would help me by going back to one of the earlier slides because I recognize that one of the impetuses for the study was that in 2011 through 12 through the 2019-24 9 years, the VE for 65 and older was significant. And so what I wanted to do is look at the HD versus the standard dose, the adjuvant versus standard dose, and the RIV versus standard dose in illnesses, outpatient, and hospitalizations. And I'm trying to understand how many Cs, when you're saying they favor the high dose and favor AAIV and favors RIV, are we talking about? Thank you.
Thank you. Let's find that slide. So, Dr. Paling, did you want to start with the VE slide that you mentioned first, or was that used to just refer to the evidence table slide?
The evidence table slide.
Got it. Okay, just one sec. We'll figure out which one that one is. Can you delegate it to me or no? Would that work? I'm just, I can't scroll. Actually, hang on one sec. Sorry, Dr. Paling, we're finding it. Technical issues. Okay, so this would be slide number 18, I believe.
Yeah.
Okay.
And so, yep, this is it.
One of the issues that we noticed in looking across studies, since we had really a pretty sizable amount of retrospective cohort data in the sort of canon that we retrieved through the literature search. One of the things that we noticed looking over the various studies for most of the comparisons, and it was particularly inherent in the 3 studies by Azurieta et al., which use relatively similar methodology on a very large Medicare population for 3 consecutive seasons, is that overall it seems that the estimates for outpatient and ER visits are a bit more inconsistent than, say, for hospitalizations. And it's difficult to know exactly where that is coming from. One hypothesis that we discussed is the possibility that since these are diagnostic code-based outcome definitions, the majority of them used, for example, ICD-9 pneumonia and influenza codes. Some of them were a bit more restrictive and used only influenza codes. You might be more likely to get assigned that diagnosis on your coding sheet if you had ended up in the hospital, say, and gotten a test, as opposed to if you're seen as an outpatient or in the ER. But we did not always see benefit in outpatient versus ER studies. And in this particular case, for the 4 retrospective cohort studies combined, we did. One thing to note about this, though, is that we're sort of comparing when we talk about looking at the flu VE network data and what we see in terms of VE versus this kind of data from a retrospective cohort study of CMS data. There are a lot of differences. There are first, that U.S. flu VE data does have laboratory confirmation, whereas the Medicare data, the retrospective cohort data, is by and large all code-based outcome definitions. The sample sizes for flu VE network are far smaller, in the thousands as opposed to in the millions with the CMS analyses. And even if you were looking at data, from the same season, you might not be able to draw a lot of parallels there, I think. Another thing to consider too with the flu VE network data, which has occurred over time, is that the proportion of people who are receiving particularly the high dose vaccine in the flu VE network data has increased since high dose was introduced. It was not very high uptake at the beginning, but particularly since the 2014-15 season, the use has gone up considerably. And now also there has been a lower proportion of, but still some, recombinant and adjuvanted use. So it is difficult to draw parallels between the two. They are, while they're, the end goal is to assess the same thing, which is vaccine effectiveness, they are measuring these things in very different ways and on different populations, with the VE network population, particularly of 65 and older, being much smaller than anything we'd see in a Medicare database. I'm not sure that gets the question. I'm sorry, Dr. Paling.
It does. And then what I was trying to look at is how many seasons for the flu hospitalization and death. And I see that of the different types of studies, for 3 of the 4 in hospitalizations favored HDIV over multiple seasons, and over 3 seasons, the retrospective cohort for death. So that's very helpful. Can we look at AIV and RIV, the next 2 slides, I believe? And thank you.
So for this comparison, we have fewer studies overall and fewer seasons represented. There is some variability in what we see with outpatient and ER depending on the study type. It was interesting that the 2 retrospective cohort studies for adjuvanted versus standard dose that are on the second data line on the graph, if you looked at each of them individually, they actually had results suggesting efficacy, but one favored one vaccine and the other. There's some variability again and also these were relatively tight intervals.
All right, thank you.
One of the reasons we have fewer data for the outpatient than hospitalizations is that Izurieta's group, in their large 3-season analyses, they only did the outpatient outcome for the first season, 2017-18, and they didn't report it in 18-19 or 19-20, so we have a little bit less to go on.
Thank you. Dr. Daly?
Yeah, thanks so much. I have 2 questions. The first question, thanks for this wonderful presentation, Dr. Groskopf, is how many of these studies were industry funded, and was that just something that was discussed during the work group consideration of the body of the evidence? And then I have a second question.
To be honest, I cannot recall the exact number, but what I can say that the RCTs that we have, so the large RCT for the high dose versus standard dose, the 32,000 person 2-season study was an industry study. The comparison study for the recombinant versus standard dose, the single season study, that was also an industry study, as was the one RCT for adjuvanted versus standard dose, which was not as helpful to us from an efficacy point of view, simply because the outcome used was just a symptom-based influenza definition. That was mostly a safety study, but I believe that was industry funded as well. And among the observational studies, the large CMS database studies that we were just speaking of, Azuria et al., those are U.S. government work. However, there were also some of the large retrospective cohort studies that were either funded by manufacturers or had industry authors. So it was a bit of a mix.
Okay, great, thank you. And then on an entirely different topic, what can we do to make sure that health inequality is not exacerbated by this recommendation? And I had two things when you were going through that, and thanks so much for that equity discussion. One was that maybe there's settings where only standard dose is offered, and those settings may be more likely in communities of color or sort of in disadvantaged parts of geographic areas. And then the second is sort of this awareness issue, and if somebody over the age of 65 is seeking vaccine but really doesn't know that there's a high dose or adjuvanted recommended for them, then they may advocate less on their behalf. So I guess those availability and awareness issues. So in the context of what we can do to make sure that this doesn't increase inequality. Thank you.
That's a really important question. I think one thing that would be helpful, and we're trying to figure out some ways to do this, is to get a better sense of why. What makes these situations different from other situations, and why these things are happening. Some of the things you mentioned definitely seem like they could be contributory. Certainly not having, a good linkage to care and probably a stable relationship with a healthcare provider or a group of providers could be a factor. We know that for just the question of getting a flu vaccine versus not, one of the strongest determining factors is that the provider makes a recommendation for it. And having a provider that you know and trust is an important thing. There are possibly also logistical issues and issues with some clinical settings that are not sufficiently staffed or don't have good enough connections with other clinical groups to be able to efficiently handle multiple different influenza vaccines, particularly if they're in smaller areas, serve smaller populations. In some cases, those might be, more conveniently thought to more conveniently be able to stock a vaccine that can be used for a broader range of the population under their care. I think probably the primary thing, though, is to get a better sense of what the root causes are, and there probably are multiple of them.
Thank you.
Thank you. Dr. Sanchez.
Yes, thank you. And really, thank you for this really great presentation and very comprehensive and lots and lots of information. I, first of all, just want to agree with the final recommendation that was made by the work group. I do think it's important, and I do favor that recommendation of the high dose adjuvanted or adjuvanted vaccines for this population. And then full disclosure, I am in that population group. But I also want to mention the importance of education. I want to re-echo Matt's comment, because it's not just education for the public, but it's also education for providers. And I think that is really essential. If we are to make this recommendation, it really needs to go out and to the general public, but also importantly to providers. Thank you.
Thank you.
Thank you, Dr. Long.
Yes, a comment more than question. Congratulations, kudos, Dr. Grosskopf and Dr. Talbot for extraordinarily well investigated and presented data, and very helpful to have the bit of the nuances of work group considerations, which were very thoughtful, thorough, the conclusion logical, and I certainly agree with the work group conclusions. The small things that I would just add to that are that it is just amazing, isn't it, that here's a vaccine that we try to give to the entire U.S. population, and its efficacy for influenza-like disease is quite low. And it's, again, the tyranny that we have learned from coronavirus of respiratory only mucosal infection, although you feel, my husband would say when he has something like this, he has viremia. In fact, he probably does not. These are mucosal infections with inflammatory signatures. And this, because the virus changes so much, we still wish we could get a little better, but maybe we should in future give up what we can't have, which is an awful lot of control of simple disease, and focus more on hospitalizations and deaths. And this intervention that could save, or would be estimated to save, an additional 2,000 deaths per year of those over 65 is truly remarkable and also cost saving. I think the recommendation is also very important, because even in healthcare organizations, when I've been aging a little longer than Dr. Sanchez, but I remember that so healthcare workers are aging, and it hasn't always been obvious that the organizations, as they're offering mass immunization, will pay attention to vaccines that are more effective in those over 65. So this will take away any of the arguing that we have to do to be sure to make the most potent vaccines for this age group available. So thank you very, very much.
Thank you.
Thank you. Dr. Talbot, did you want to make a comment?
Yes, thank you. I just, in reply to Dr. Daly's question, it is really easy to stock, it's much easier, I should say, to stock one vaccine and just give everyone that one vaccine. And I think many have done that because it is so much easier. I think that also has created a disparity that you're referring to. And so moving to a recommendation that an older adult should get a relatively better vaccine would then change that game. And so it becomes a priority then to identify those patients over 65 and give them the correct vaccine. And so I think this move will help improve and reduce the disparity that we're currently seeing. Thanks.
Thank you. Dr. Goldman?
Thank you. First, really well done, excellent presentation. Such amount of data, really well explained. A question and a comment. In regards to that 2015 study where they looked at equity, did they subdivide it for Medicare Advantage plans versus straight Medicare? And I bring that up because one of the quirks of vaccine reimbursement is that certain vaccines like flu, pneumonia, hepatitis B are under Medicare Part B, versus the others are under the drug plan, which in some cases, especially with the full risk plans, may actually prevent physicians from being able to vaccinate in their office, which may further decrease access, availability, and equity. So one, did they look at it? And two, do we consider any of that in the nuances of how we can increase equity, especially allowing physicians to be able to administer certain vaccines in their office? Thank you.
That is a good question. I actually am not certain of the answer for that specific paper. Are Medicare Advantage plans Part C?
Yes, they are also called Part C.
Part C, okay. The Azurieta analyses and the other analyses from that group, which is out of FDA, by and large have excluded Part C from those analyses. I cannot remember, honestly, for the Mahmood paper, what the status of Medicare Advantage plan participants was in those analyses, but I can easily find it out for later today if that would be helpful.
Thank you.
Thank you.
Thank you. Dr. Long?
Yes, I have one comment I forgot. You know, I'm getting more confused as we go along with so many recommendations. What are shoulds and et cetera. So the should question here is, it seems that the recommendation is straightforward, but the recommendation also has always embedded in it, if one of these vaccines is not available, give the standard vaccine. I would rather we said that high dose or adjuvanted vaccines should be made available for people over 65. We want to save those extra 2,000 lives. We want to be sure that all the doctors understand that they should be giving these vaccines in preference. So I think that the way we've seen so far, it still is a little too passive. But I don't know how proactive we can be about this and where that might happen, Dr. Leah, in the recommendations.
Yeah, thank you, Dr. Long, for bringing that up. I actually, I agree with you, but we do have another session where we will look at the vote recommendation. So if we can bring it back up when we have the vote language in front of us, I think it would be terrific to do that. Dr. Freihofer.
Sandra Freihofer, American Medical Association, speaking as a practicing physician who administers vaccines, flu vaccines in her office, and who orders flu vaccines for her office generally in February of every year. So I think one thing that we need to make sure is that we don't keep people this current flu season from being vaccinated. You know, this recommendation, if the committee decides to vote on this, would very likely affect the supplies that physicians have in their offices. So as you make this recommendation or vote, please consider that. We want to make sure that patients can be vaccinated, and certainly do appreciate the hard work that has gone into this presentation by the flu vaccine work group. So thank you so much.
Yeah, thank you, Dr. Freihofer. It's always extremely helpful to have the frontline perspective. Dr.
Yes, this is Kathy Paling. I've got another question. Among the persons over 65 years of age, do we know what percent are vaccinated in a pharmacy versus a physician office?
I'm uncertain of the exact answer to that. Vaccination in pharmacies is obviously something that's been increasing over the last number of years, and I understand is fairly commonplace. I'm not certain of the exact proportion. That's information, though, that we can get and come back or bring it prior to the vote if possible, if that's what the committee wishes. One thing, though, related to that is that it does seem that these vaccines are readily available in retail vaccination settings. They're advertised, for example, if you go to try to book. You can't do it now because flu vaccine's over for the season, as I found out when I tried to do my clandestine research in the last couple of weeks. But in previous months, if you were to, example, try to go book an appointment for flu in Walgreens or CVS, you will generally see one or the other of these.
Okay.
In case that's
very
helpful
helpful
information.
Yeah, that's very helpful. And so I wanted to make sure, and it also seems like as we're thinking about these adult recommendations, making sure there's a universal registry so that there's clear communication between the practices and the pharmacy would be very helpful. Thank you.
Thank you. Dr. Lee, may I just reference back to Dr. Goldman's question about that disparities analysis and Medicare Advantage? It did exclude Part C, so Medicare Advantage was excluded.
Thank you. I also will make one point and ask a couple of questions. First, I just want to commend the work group, your leadership, Dr. Talbot's leadership, because this is a tremendous amount of data, and you have synthesized it so succinctly and efficiently, and we really appreciate that because we recognize the literature is vast and variable, and it takes a lot of work to get it into this form and make it easy for us to deliberate on. So really appreciate all of that effort. I had a couple of questions. It does follow along the lines of some of the questions that were asked previously, including the one by Dr. Paling. So, and I thought we weren't going to say the word COVID today, but Dr. Long already brought it up. As we've learned from the COVID pandemic, our pharmacy partners have been incredibly helpful in ensuring that they are a key part of the delivery system, and that has been longstanding for influenza vaccines, in addition to our physician offices who have done a huge amount of that vaccine delivery. It would be incredibly helpful to have that information about what proportion of individuals by age group receive vaccines in pharmacies versus offices. And I'm thinking more broadly, but specific to the flu vaccine, it would be great to know for the flu vaccine. And what products are available. To get to Dr. Daly's point about whether or not regional or local variability and availability could adversely impact some communities more than others if pharmacies are a predominant delivery system in certain communities for receiving that flu vaccine. So I think that'll be really helpful, in part because we would look ahead to what can we do to reduce disparities, and having that information would help us, I imagine at the state and local level, ensure that we can partner with our colleagues in the community to ensure that we're closing that gap from an implementation standpoint. So I think that data would be really helpful, and we'll emphasize again that education, community outreach continue to be key and important points. And so sustaining the relationships that have been built over the course of COVID, my hope is that, I know that resources are dwindling again, and that all of the efforts that we've made to engage community partners have been critical for the COVID-19 response and in reducing disparities. However, I worry that as attention fades and funding fades, that we are going to be missing out on really important opportunities to continue to address disparities and health equity. And, I recognize this is not necessarily an ACIP or only a CDC issue, but would really just emphasize the importance of federal funding that is not just related to COVID, but it's related to all of our vaccines, all of our preventive health issues. There's so much more we have to do. Just a comment there. But the two questions I have in follow-up, I have one simple question, which is, looking at the cost effectiveness analysis, I think it makes a lot of sense, the recommendation that was proposed. My question is, what are the costs of these vaccines? Is there any difference between the vaccines? I saw the cost effectiveness analysis, but I'm sorry if I missed the actual cost per dose of these vaccines. And then the second also is just in terms of additional information would be to understand what the vaccine safety monitoring plans would look like going forward. Is this something that would be monitored, for example, by CMS and our FDA colleagues in post-market safety surveillance? I think that's a great opportunity, and or our VSC colleagues, but it does seem like the vast majority of recipients would be CMS insured. So those are my two questions for you.
Thank you. For the first question, that was my fault. I neglected to include in my description where the cost assumptions were drawn from. This is sort of a tricky thing to get a definite grasp on. To find out the average retail price of these vaccines is generally fairly tricky. We were not successful in determining what the average wholesale price was. Our understanding that the prices for the different vaccines can vary somewhat depending on what the purchasing power of the purchaser is, how much they're buying, and what sort of price can be negotiated. So the analysis that I summarized was one which used for the cost assumptions, the CMS reimbursement rates, which for the three vaccines in question, as you saw, are pretty similar. They're roughly 65 and change to 66 and change for each of those, versus for a single dose presentation of the standard vaccines. And we're talking single dose presentation for comparison here, mainly because there are no multi-dose presentations for the for the higher dose and adjuvanted vaccines, they're all prefilled syringes. Those are roughly $20 to $21 unless you're talking about the cell culture vaccine, which is a little more expensive. We did have some discussion about this with our econ group, and they typically use those numbers rather than a wholesale price for these analyses. For the second question with regard to safety, within VAERS and VSD, there are certain safety events that are routinely monitored for, and I would anticipate that would continue, although I'd have to defer to colleagues in Immunization Safety Office for more details on that.
Yeah, thank you. If that information is available prior to a vote, that would be really helpful just for a quick update. Dalton.
Thank you. Again, just want to make a comment, and certainly as a private practice physician who also gives all vaccines in my office, including flu shot. And I just want to point out, and no disparagement to my colleagues in the pharmacy world, I think they have been incredibly helpful during the COVID pandemic and in their assistance with getting outreach to various patients. But I really want to make sure we also don't neglect or forget the physicians who the patients trust the most to advise them, and how the system is being shifted to take vaccines out of physicians' offices between reimbursement issues, being able to keep the door open, and systems that are making it more and more difficult for us to administer vaccines. I really want to emphasize that while we do need our pharmacy partners, we can't forget the physicians who are also vaccinating. I've had patients get 2 or 3 doses of flu shot at a pharmacy within the same 2-month period because they're not using the registry, they're not communicating with the physician offices, they're not having, as was referenced before, a centralized database. So if we are shifting and including the pharmacies, we really need to emphasize the importance of partnership, collaboration, but also remember that the physicians are the leaders of the healthcare team, and we really need to be included in the vaccination efforts. Thank you.
Thank you, Dr. Goldman. And yes, 100% agree. We want to make sure that the care that is needed is delivered in primary medical homes. So I appreciate your statement. Dr.
Yes, I lost internet connectivity for some of this discussion, but I wanted to, and I believe you've covered this, but I wanted to just make sure that I think people know that some of the other QIVs are less expensive than the 3, preferred vaccines or, that are being discussed. And I don't know if, like in some systems, I've heard from some AIM colleagues that they're concerned that in some systems, they may not be making available the higher priced vaccines. And I don't know, what kind of language could be used when you're thinking about the vote and the final recommendation, if that's clear. I know.
Dr. Groskopf?
So I just want to try to understand the question better, Dr. Lett. Does it have to do with restrictions being put on what healthcare systems can purchase because of expense?
I think it was, I think the question was raised on a call that certain systems, can you hear me?
Yes. Mm-hmm.
That certain systems might be buying the less expensive standard dose vaccine, and the encouragement, of making sure that the preferential vaccines will also be available. Because it's like perhaps that there was concerns that if there were systems with fewer dollars available, but trying to enhance adult vaccination, might just buy or make available the less expensive QIVs. Does that make sense?
Right. Yes. No, I see what you're saying now. Sorry. I understand that, and I think there was some discussion about that. On the one hand, all of these vaccines are reimbursable under Medicare for those who are eligible. So, if they were administered to somebody 65 and older as opposed to somebody, say, 50. And also they're reimbursed at a higher rate, but that still does require spending more on the front end to purchase them. And I imagine, although I'm not 100% certain, that being reimbursed for them requires actually having administered them. And we do know that in general, every year there are many doses of vaccine that are discarded. I'm not making that comment with respect to these vaccines specifically, but just influenza vaccines in general, just because they're not used. So I can definitely see the point where that would be of consideration. I think one would hope that if there is a recommendation and more public awareness that these are more recommended and potentially more beneficial, I would hope that would lead to more people getting vaccinated. But as we know from vaccine coverage, even though 65 and older is one of the higher coverage groups in the US, there still are about 25 to 30% of those folks who don't get vaccinated. So,
and I'm thinking, I guess there could be some uninsured individuals. So
true.
That some of these safety net funds or vaccines are being. So that was sort of something that was expressed on a call that I was on that they wanted me to raise today. I don't know if we know the answers, but they just wanted that raised.
Thank you, Dr. Lett. Dr. Talbot, did you wish to comment or respond?
Yeah, just briefly, I think Dr. Lett and Dr. Long have both brought up the issue of the language, which was at the last part of the recommendation about getting whatever vaccines available. And I think the committee was very concerned that if someone went to a pharmacy and they didn't have one of these newer vaccines, that they would not get vaccinated. And the idea was to allow them to get a standard if nothing else was available so that we don't have a missed vaccination opportunity. It may not have been the best wording, as Dr. Long has mentioned. And so I think when we come back to the actual language of the vote, we'd be very happy to hear if there's something that you feel can close that loop up. You absolutely should be buying the correct vaccines for older adults. However, never miss a vaccine opportunity. Thank you.
Thank you, Dr. Talbot. And to further your point, I also just, one of the ways that we've reduced disparities in children is the Vaccines for Children's program. I mean, and to just comment back to Dr. Goldman's discussion points around, first dollar coverage for, or how should I say this? Frontline providers not only do a huge amount of counseling, preventive care, and just health care for our patients, but they are actually asked to bear the burden of that cost for upfront as we deliver vaccines. And vaccines are unlike any other sort of intervention that we do. A vaccines for adults program could be incredibly impactful and powerful in reducing these disparities, and particularly as we have more and more vaccines available for adults, being able to help our provider communities deliver these without financial risk to the providers, I think would actually go a long way as well in making sure that we are delivering the care that's needed in the moment that providers are there caring for those patients. There are many providers who don't carry vaccines because it is a financial cost up front that you're not sure is going to get fully reimbursed at the end of the day. So it is a service and it is an important public good and one that we should emphasize and support going forward. I will get off my soapbox now. Dr. Grosskopf, I think probably we should move to the next slide deck and discuss the vote language, if you would please go ahead.
Okay, one moment, please. All right. Okay, so thanks very much. That was wonderful discussion to hear. This next presentation is a summary that contains a brief influenza vaccine safety update, which is something we typically do in June when we can, and an overview of the proposed recommendations for the 2022-23 influenza season. First, I want to thank and acknowledge the work group members who were listed in Dr. Talbot's slides, who have had many, many more meetings than we typically do in a typical year, both for flu as well as for COVID over the last several months, as well as the CDC staff attendees and others who have contributed to the work group's discussions. Next slide. So first, the influenza vaccine safety update. This is just a couple of slides, and we are very grateful to our colleagues at the CDC Immunization Safety Office for preparation of them. Next slide. We're not providing this update to give information about anything of particular concern. This is just an update on a few points. First, for the 2021-22 season, approximately 175 million doses of influenza vaccine were administered in the United States. In the Vaccine Adverse Events Reporting System, or VAERS, no new safety concerns were identified. Within the Vaccine Safety Data Link, or VSD, approximately 5.5 million doses of vaccine were administered, and again, also for this system, no new safety concerns were identified. Excuse me, I've been asked to move microphones. Just 1 second, I will be back. Okay. Hopefully I'm audible. So the next slide, which we're on now, good, okay. So this is just an update about a couple of the Vaccine Safety Office, Immunization Safety Office studies that are in progress. Within the Clinical Immunization Safety Assessment Project, or CISA, there are 2 ongoing studies that have been enrolling this season. They're both co-administration studies, and they're not currently enrolling since vaccination for the season is essentially ended or close to ending. However, they will resume enrollment during the 2022-23 influenza season. These include an evaluation of the safety of simultaneous versus sequential administration of mRNA COVID-19 vaccines and quadrivalent inactivated influenza vaccine. This study enrolled 73 participants aged 12 years and older during the 2021-22 season. Again, it's on a break from enrolling now until the flu season starts again. There was a safety panel assessment which noted no safety concerns, and this study again will resume enrollment for next season. A second study assessing the safety of simultaneous vaccination with zoster vaccine recombinant and the quadrivalent adjuvanted inactivated influenza vaccine, or AIIV4, enrolled 102 participants aged 65 and older during the 2021-22 season. Again, also not currently enrolling, but this will resume in the fall. There was a safety panel assessment of this, which also identified no safety concerns. Next slide. Before moving on, I want to thank our VAERS and VSD teams, the CISA project, and colleagues in the Immunization Safety Office who we work very, very closely with, as well as in the Influenza Division and in the FDA Center for Biologics Evaluation and Research for their work. And also we're grateful to healthcare providers and health departments who are reporting to VAERS and to individuals for participating in clinical studies. Next slide. So the next part is a summary of the proposed recommendations for the 2022-23 flu season. The draft 2022-23 ACIP influenza statement contains many recommendations that are similar to previous seasons. The core recommendation that annual vaccination is recommended for all 6 months and older who do not have contraindications stands, and we hope to reaffirm that on vote. There are 3 main updates. One is the U.S. influenza vaccine composition for 22-23. There's also a section on the change in the approved age indication for Flucelvax quadrivalent. This is the cell culture-based inactivated vaccine. This change in age indication occurred in the fall, so it occurred after the publication of the last statement. And finally, the main topic of discussion today, a proposed new recommendation of language for influenza vaccinations of persons aged 65 years and older. Next slide. So the first thing on that list was the U.S. influenza vaccine composition for 2022-23. The vaccine composition from next season contains updates for 2 of the 4 viral components. As was the case for 2021-22, all influenza vaccines in the United States are anticipated to again be quadrivalent next year, so we don't have any more trivalents. And these are vaccines that contain hemagglutinin derived from one influenza AH1N1 PDM09 virus, one influenza AH3N2 viruses, and then two influenza B viruses, one from each lineage. There's the Yamagata lineage and the Victoria lineage. For 2022-23, there are updates to the influenza AH3N2 and influenza B Victoria strains. U.S. licensed egg-based inactivated influenza vaccines and the live attenuated vaccine, which is also egg-based, will contain hemagglutinin derived from an A Victoria 2570 2019 H1N1 PDM9-like virus, an A Darwin 9 2021 H3N2-like virus, that's one of the updated ones, a B Austria 1359417 2021 Victoria lineage-like virus, that's the second updated one, and a B Picot 3073 2013 Yamagata lineage-like virus. The cell culture-based vaccines and the recombinant-based vaccine will contain an A Wisconsin 588 2019 H1N1 PDM09-like virus, an A Darwin 6 2021 H3N2-like virus, a B Austria 1359417 2021 Victoria lineage-like virus, and a B Picot 3073 2013 Yamagata lineage-like virus. Next slide. So the second update is the change in age indication for Flucelvax quadrivalent. This is the cell culture-based quadrivalent inactivated influenza vaccine, or CCIIV4, as it's abbreviated in our documents. This vaccine was, up until recently, licensed for ages 4 years and older. It was approved in March, prior to the implementation of the current season's recommendation, March 2021, for ages 2 and older. Subsequently was approved in October 2021 for ages 6 months and older. One of the interesting things with this particular change is that with it now all of the standard dose non-adjuvanted quadrivalent inactivated influenza vaccines are licensed for ages 6 months and older. There are a total of 5 of them. 4 of them are egg-based. Up until recently, this was the last one that wasn't licensed for children as young as 6 months. Next slide. So lastly, the work group drafted some proposed language for consideration for a new recommendation for influenza vaccine for persons aged 65 years and older. As currently drafted, the language reads as follows. ACIP recommends that adults aged 65 years and older should receive one of the following higher dose or adjuvanted influenza vaccines if available: quadrivalent high-dose inactivated influenza vaccine, quadrivalent recombinant influenza vaccine, or quadrivalent adjuvanted inactivated influenza vaccine. No preference is expressed for any one of these 3 vaccines over the other 2. If none of these 3 vaccines is available at an opportunity for vaccine administration, then any other age-appropriate influenza vaccine should be used. So that includes the summary of the proposed recommendations and my updates. Thanks for your attention.
Thank you, Dr. Groskopf. Yeah, thank you. So as a reminder, just for our ACIP members and the public, typically what we'll do is discuss the potential vote language and make a motion on that, but we will not vote on that until after public comment. We do have a series of planned votes for today. So for now, we will just focus on the vote language and the motions, but we will not move to a vote until after public comment. So I'll open this up for discussion, and perhaps we can continue some of the discussion that was happening previously. Dr. Schmader, you were quick. Please go ahead.
Thank you, Dr. Lee. To the ACIP voting members, I just want to let you know the American Geriatric Society strongly endorses the preferential recommendation for high dose and adjuvanted influenza vaccines over standard dose vaccine as presented here. AGS sees this as a long overdue improvement in influenza vaccination policy for older adults. And I want to make one other point. There's a population of older adults who do not receive vaccine in provider offices or retail pharmacies. That's the estimated 1.4 million residents of long-term care facilities who are vaccinated on site. And this recommendation will provide clarity for that group as well. Thank you. Over.
Thank you, Dr. Schneider. Dr. Feng.
Did you call on me? Something happened to your voice in the middle of it, yes? I would suggest, for starters, ACIP recommends adults aged 5 and older preferentially should receive. I would put preferentially in there. And I would take out the if available at the beginning. So preferentially should receive. And then the next part is all fine. And I would just send there is no preference between these vaccines. If you say one of these and 3 of those and 2 of the others, I think it makes people wonder if you're talking about standard. So with no preference between these. And then if none of these 3 vaccines is available at an opportunity, then any other as, I still wish we would say they need to try harder. But I think help to make preferential in the first part of it, take out if available after the first part of it, I'll only get to that later, and just no preference between these vaccines.
Thank you, Dr. Long. Dr. Paling.
I really like Dr. Long's suggestions and agree with it. My only other recommendation is to say there's no preference among these 3 vaccines. Thank you.
Thank you, Dr. Paling, for the grammar correction.
Thank you. And I'm just going to warn folks that we have electricity outages over here. So if I come in and out, I apologize. I will just do my best to keep up with everyone. Dr. Hogue.
Thank you, Dr. Lee. I apologize that I had to step out for a little bit of the conversation, but I understand that there was some concerns about ensuring that when pharmacists are administering doses of vaccine, that those actually wind up in the registry so that other care providers are able to see the immunization event. And we feel at the American Pharmacists Association that the vast majority, if not all, of the major national pharmacy chains have connected their computer servers to the state immunization registries in those states where such connectivity has been allowed. And those pharmacy providers are, in fact, feeding data to the greatest extent that it's possible to send such data. Independent pharmacies, as we may know, there's about 20,000 of those in the United States. And those independent pharmacies have been making special efforts with their state health departments also to get connected. But as we all know, the funding for registries and so forth and getting folks established has been woefully lacking. But I do believe that there's a commitment. I know there's a commitment on the part of the pharmacy community to make sure that immunization registries are complete and the type of vaccine that a patient's received are recorded accurately in the registry. Over.
Thank you, Dr. Hogue. Dr. Sanchez.
Yes, thank you. I also want to agree with Dr. Long and Dr. Paling. And I agree that the wording, taking out the 3 over the 2, I think it's preferable to just leave between any of the vaccines. But I also do think I really do want a preferential, preference for these higher dose or adjuvanted influenza vaccines over the standard. And this is kind of a wishy-washy type recommendation. And can the language that if they are not available, that any other age-appropriate vaccine can be used. Could that be in the communications rather than in the vote? Just say that ACIP recommends preferentially these vaccines over, standard dose, whatever. But then take out the other and make it more of a one of the communications that that get published along with the recommendation.
Thank you, Dr. Sanchez. I'm going to call on our next two folks who have their hands raised. We are going to probably take a pause after this, so if there's any other edits or changes that are suggested by committee members, please feel free to chime in now. We'll take our 10-minute break early, and then we'll come back after the break and look at the revised proposed language. So Dr. Lett.
Yeah, so, I'm really not, again, the best wordsmithing person amongst all you experts, and I don't know if it belongs in the vote, but just to keep in mind, these safety nets, vaccine purchasing, and I think, Dr. Lee, you had mentioned, the Vaccines for Adult program, and that people make available the preferred formulations, again, because of the price differential. I don't know where this belongs, but I just wanted to bring it up one more time. And Dr. Freihofer may have a better idea.
Thank you. Actually, we're going to move to Dr. Lehrer and then Dr. Freihofer.
Thank you. As a member of the work group, there is a strong feeling that we did not want to miss an opportunity to vaccinate. And that's actually why the word, if available, was in there twice. However, I am intrigued by Dr. Sanchez's idea of taking out the last sentence and putting that information into the additional communication, emphasizing the preferential aspect of this, and somewhere else saying, if it's not available, go for another vaccine. It's a question of emphasis. Where do you want to put that information so that everyone sees it? Thank you.
Thank you, Dr. Lehrer. Dr. Freihofer?
Sandra Freihofer, American Medical Association. Speaking as a practicing physician, I strongly advise not taking out that last sentence. Again, as I mentioned, physicians have already ordered their flu supply for this year. If you take out that last sentence, I fear that we will be denying patients any flu vaccine whatsoever. And not having that sentence there, you're basically saying it's like this way or the highway. So I would encourage you, I think the language that the work group has presented is very good language when it comes to that last sentence. So please keep that sentence there.
We'll go to Dr. Brooks.
I'm in concurrence with Dr. Freihofer, and for the same reasons, it's something that Dr. Lehrer also referenced. I'm worried about a missed opportunity. I also think back to the equity slides where there were lower rates of high dose given to relevant minorities, African Americans, Latinx, and Asian. And I think, therefore, that the way this is stated is appropriate. Also, if you add prefer to me is weaker language than should receive. So I think that I would just remove the words over the other two. But otherwise, I agree with the language that's written.
Thank you, Ms. Bata.
Thank you. I do support changing this language to maybe take out the if available at the beginning. And as Dr. Freihofer mentioned, vaccine ordering has already occurred. And so we are in a position where clinicians and clinics may not have a preferred. I understand the desire to make this a strong statement. But I also want to just raise the point that the evidence that we have is incredibly varied and, has been graded
low and very low in several aspects of the evidence. So, I wonder if we're moving so fast to make this really strong language, and that from a clinical perspective, I may be missing that the intent of that, but I think we need to include some aspect of you don't want to miss the opportunity.
Thank you. Back to Dr. Sanchez.
No, I hear the concerns and certainly the fact that many offices and healthcare providers have already ordered these vaccines. I just feel that I just feel like we do so many clinical considerations that part could be stated there, and it would still be another way of providing other vaccines if these high dose adjuvanted vaccines are not available. But I guess my question is, should we be bringing this up for another vote later? Because it seems to me that it's the reason we don't want to do the should of these vaccines is because there's already been ordered, and maybe this is not the appropriate time to make one. It's not the appropriate time to exclude the other vaccines from the recommended language. Just commenting in terms of maybe this is something that we need to bring up in a more opportune time.
Thank you, Dr. Bell.
I just wanted to agree with Ms. Bata and Dr. Brooks. And to Dr. Sanchez's point, it is always possible to update a recommendation, but I think under the current circumstances, given the body of evidence and all of the logistical concerns that all the colleagues have raised, it's important to do everything we can to avoid misconceptions and confusion that somehow or another the high dose vaccines are the only vaccines that we think people over 65 should be given. So I think for now, the language that was proposed initially is preferable, and that's what I would support.
Thank you. Dr. Long.
I'm loath to disagree with Dr. Bell. But don't you think, we saw that 80% of people over 65 are already getting a high-dose vaccine? I mean, because we're just seeing this now, this is not new information. I mean, it has looked in many studies as if high dose is more effective in this age group, and the other vaccines, the standard dose, are not very effective. Why would we miss the opportunity to save, I think, a conservative additional 2,000 lives, not 20, 2,000 lives, and do that preferentially for poor people? I just don't see that playing out in an equitable way. I think we should say that what we know, they're better and they should be used. And if you can't use them, I'm not going to argue about where you put this if it's available. If it's not available, I won't argue about that.
Thank you, Dr. Schaffner. Dr. Schaffner, my internet might be going out, but others here, Dr. Oh, there we go. Thank you.
Hello, Dr. Lee. I heard you that time. Thank you very much. Returning to the first sentence, the National Foundation for Infectious Diseases is glad to join others in suggesting that the language should be age 65 years preferentially should receive one of the following higher dose, et cetera, vaccines. And we would leave the if available to in some form to the end of that statement. But we certainly strongly endorse a forceful initial statement. Thank you very much.
Thank you. And I like that wording, Dr. Schaffner. I don't know how we're going to end up, or I don't know how Dr. Grosskopf is going to end up with the final language when we come back from break. But I also agree with Dr. Schaffner and Dr. Long. I feel like there's no other recommendation that has this level of detail in our vote, which is if none of these 3 vaccines is available. That is typically for me in our clinical considerations, and I think we should emphasize in the clinical considerations the importance of health equity, reducing disparities, and the pragmatic considerations, and the importance of not missing any opportunities for a vaccine. But I feel like the vote language should be focused on what the vote actually is. That said, I can live with it for this year since I know we revisit this recommendation every year. So if there is a strong preference to include it for this year, given the ordering is complete, I can be okay with that. Any other comments or questions? Anything different people would like? Okay, I don't see any hands raised, so why don't we take a 10-minute break? We'll meet again at 32 minutes after the hour. We will review the vote language at that time, and then we will put motions on the table. Thank you.